Welcome to episode 236 of the Fabulously Keto Podcast. And today I'm interviewing Dr. Andrea Salcedo. I was introduced to Dr. Andrea by my friend and previous podcast guest, Dr. Joanne McManamy, and I'm so glad she made the connection. In this episode, Dr. Andrea shares her personal and professional journey into women's metabolic health and how conditions like fibroids, PCOS, and perimenopause are deeply connected to insulin resistance and lifestyle. We talk about everything from gestational diabetes and sleep to fasting and the fascinating biological purpose of hot flushes. It's a conversation full of insight, and I think one that will resonate with women at all stages of life. Here's Dr. Andrea's bio. Andrea Salcedo, DOMPHFACOG, is a board-certified obstetrician and gynecologist. Wife and mother of 3 young boys, she practices full-scope obstetrics and gynecology at Loma Linda University Health, an academic medical center in Southern California. Her clinical practice is diverse, ranging from low-risk women's health care to complex gynecologic and obstetric problems. A large part of her practice involves root cause investigation into the development of gynecologic disease. Particularly, she focuses on metabolic health as it relates to the development of uterine fibroids, endometrial polyps, and endometriosis. She has a special interest in using non-surgical strategies to treat endometriosis. Dr. Salcedo is a clinical researcher and published author in peer-reviewed academic journals. She has spoken at several conferences, including at the prestigious Symposium for Metabolic Health in San Diego and Boca. She is a clinical instructor for the Nutrition Network and has been featured on several podcasts. She also serves as an expert for the Osteopathic Medical Board of California. She is an active member of the Society for Metabolic Health Practitioners. She also has a YouTube channel that promotes metabolic strategies to treating gynecologic problems called Conscious Gynecologist. She has an active telehealth practice where she consults on a metabolic approach to treating gynecologic diseases. She is fluent in English and Spanish. Dr. Salcedo has a passion for cooking, lifestyle design, and work-life balance. She's an avid reader and often reads outside her field to make connections to what she does every day treating patients. So let's go and hear from Andrea. Welcome, Dr. Andrea, to the Fabulously Keto Podcast. It's fabulous to have you with us today.
I'm so glad to be here, Jackie. So great to see you again.
And we always start with, where in the world are you?
Yes. So I am in Southern California in a city called Claremont, and I work at Loma Linda University Health, which is a school of medicine in Southern California. Very exciting perspective because they're very much into holistic care, whole person care, also vegetarian lifestyle, which is kind of funny. But I'm always really grateful that they're willing to kind of allow me to have a purpose of focusing on women and insulin resistance. And then it kind of leads us into low carb and keto lifestyle. So that's really great. You know, I just follow the science, and you really can't dispute the science in terms of insulin resistance and how it affects women. So it's a lot of fun.
Okay, so are you vegetarian yourself?
I'm not. I'm actually not. I tried like probably 10 years ago, like many of us did, and I just wasn't full. I just couldn't get full. And so, but I am a Catholic. And so on Fridays during Lent time, we fast and abstain from meat. And so it's really hard, like when we're, so used to such an animal based lifestyle. And then on Fridays, it's kind of hard. We kind of let that go, but I'm starving. My kids are starving and stuff. And so it really does help us understand how helpful it is in our diet.
Yeah. And they're fine on Loma Linda if you're not vegetarian, I guess.
Yeah, they are. You
plant-based?
would think because there's so much, thoughts and ideas about what the Seventh Day Adventists and Loma Linda University community promote. And really it's healthy living, and balanced lifestyle away from processed foods and stuff, which is really great. And it's not like a ban on meat, it's mostly just that, plant-based foods seem to be healthier in their context. The cool thing is I get to work with a lot of vegetarians at Loma Linda, and they are still interested in doing like a low carb lifestyle. And so we can definitely modify it into that way as long as we get enough fat. And so that's a lot of fun because then it takes away the narrow focus of low carb lifestyle to more of like inclusivity, which is really important to me.
Interestingly, today I got a new person in my Facebook group, and she was saying how she's wanting to start, but she's vegetarian, and what resources can I give her? And actually, through the podcast, I've probably only got two people that are vegetarian of the guests that I've had that I can lead her to, because most of my guests were vegetarian for many years or vegan, and now they're not. So it's quite interesting how people tend to move away from vegetarian. So I've only got two people that I've been able to refer her to. So why don't you
Yeah.
start by telling us how you came to find low carb and using this as a protocol in your practice?
Yes. So that's a really great question. So I have three children. I'm married, and on my last child, I ended up having gestational diabetes, which was really a big shock for me and a lot of my colleagues because when we in the United States, when we take the gestational diabetes test, we're about 24 to 28 weeks pregnant. And so I was pretty light. I was like, I took it right at 24 weeks. I was about 120 pounds, which is what, like 60-ish kilo, and I failed it miserably. My 1 hour glucose test was 200, and I didn't even have to take our confirmatory test. It was like very diagnostic, and I was shocked and very slender, thin. My only real risk factor was that I was a little older at that point. I was like, I think I was 38 when I had my son. And I'm of Latin American ancestry. I'm Mexican American. And so those are kind of some risk factors. But outside of that, everybody was pretty shocked. So once I had that diagnosis, I was realizing that even things that I considered to be healthy were things that I couldn't eat. So at that point, I was eating a lot of quinoa, a lot of lentils, a lot of chicken without the skin, not so much red meat, because really I just thought that it wasn't healthy. I don't know. And I look back and I think, wow, I'm kind of embarrassed about that. But I remember just eating a lot of chicken and curries and things, but instead of white rice or even brown rice, I was eating a lot of quinoa, and my sugars could not tolerate it. Like any small amount of grains and my sugars would be really high through the roof. And I was starting to get really frustrated, realizing that like I really just can't eat carbohydrates. That was very frustrating because I really liked carbs, I really liked having crackers and cheese, and I really liked a little dessert here and there. But to how much it was impacting my pregnancy. And I definitely didn't want like a larger baby that I couldn't pass through my birth canal. And I didn't want my baby to be super huge. And there's a lot of concerns about how our sugar levels are remodulating the baby's own pancreatic abilities and metabolic health, even in utero. And so I was really nervous about that. And so my doctor didn't even send me to the gestational diabetes class because everybody just kind of assumed I knew how to manage it, but I really didn't. I just kind of did it on my own. I was checking my own blood sugars, and they were really high. And so I was just starting to decrease carbohydrates almost zero. And I ended up delivering a full term kid at 6.5 pounds. My baby was not huge at all, and it went really well. And so during my postpartum time, I started doing a lot of reading and realizing that being of Latin American ancestry in the United States, if I've had gestational diabetes, I have a 50% chance of actually getting type 2 diabetes in 10 years. And so I was like, oh my gosh, like I'm a doctor. Like there's no way that this can happen to me. Like this shouldn't happen to me, because anyone, we should have the knowledge to prevent this. And it's not just like this death sentence that's just waiting for us. And so I refused to believe that number. And I started really looking into the data and trying to figure it out and looking at some of I think it was Lily Nichols' book that I started reading and started looking into about how to take care of the gestational diabetic. And even after, I remember, in my postpartum period, thinking about getting like a boba drink, and I remember going to get a drink and all excited because I could finally have something sugary. And then within the hour, my heart rate was starting to go up and I was feeling hyperglycemic, and I checked my blood sugar and man, it was like 160. And I'm like, oh man, I really can't have any of this. And so then I found the Nutrition Network and I thought, wow, like this is really great. Like, how come we're just not treating this in terms of diet only, and what is the need for a carbohydrate? And so really I just started taking all the classes through Nutrition Network, and I just was consuming all this information. And I took about 4 months off after I had my son and felt like, wow, these concepts of insulin resistance, these concepts of what we call endothelial inflammation, damage to the blood vessels that are from high glucose and high insulin levels and inflammatory molecules can really damage organs like the heart and the lungs and the kidneys and stuff and diabetes. But then I started realizing that the uterus is an organ that also receives these same inflammatory consequences just like all the other organs do. And so then I just really just took off with my research. And when I say research, not just like internet research like we all do, I was actually starting to create clinical investigations and studies about how this impacts women. And so I've become a published researcher. I speak in a lot of scientific contexts, but also for lay people about how the uterus is an organ. We call it end organ in medicine that receives the same amount of inflammation and damage due to diabetes and in metabolic syndrome, just like any other organ. And so then women tend to get heavy periods and PCOS and perimenopausal symptoms and things like that really are related to metabolic health. And so that's where I'm at. And it's a lot of fun. And I really have a special focus in fibroids and endometriosis, but perimenopausal care and PCOS. It's a lot of fun. So thank you for the opportunity to be here and share that, Jackie.
Yeah, no, I think there's going to be lots of people that are really excited to get that knowledge at whatever stage they are in their life. And I know my friends' children are having children now, and one of them in particular had gestational diabetes with her first child and her second child. And even though I said to my friend, that is a leading indicator that she's probably going to end up with diabetes, and the children are. I don't think she then told it to her daughter, but I think it's important for people to know that it's not just something that happens in pregnancy, but it has a knock-on effect later on for both mother and baby.
Yes, I mean, it is a physiologic phenomenon. Okay. Like, so the whole insulin resistance and pregnancy is really, there's a utility for this. The reason why that actually physiologically happens at around the 20th or the 24th week of pregnancy is because the baby really starts to consume lots and lots of energy in order to support its growth. And I mean, it's an incredible piece of work how pregnancy and a woman is able to like symbiotically exist together. And it's a lot of metabolic exchange that happens. And so that higher glucose level towards the middle to the end of pregnancy is for the benefit of the baby, but it's also for the benefit of breastfeeding. Okay. And so you need some higher levels of glucose during the breastfeeding period because you're sharing nutritional value with the fetus or the neonate. And so because of that, that's normal. That's what's supposed to happen. But because modern culture, we have so much access to carbohydrates and sugar and fruit and things that before our ancestors never really had this like 12-month a year access to all of these really good foods, then our body just can't support that. And so then, it really does impact the growth of the baby. It will make it sometimes too big to pass through the birth canal. It will sometimes even remodulate a baby's own ability to process sugar in the future. And so there's a lot of really big impacts on that. So yes, it is normal phenomenon, but we just take it to the next level with our access to modern food.
Yeah, and that's what I was thinking is probably ancestrally it's normal, and in that time we probably would have craved more fruit or something that had carbs in, and we would have gone searching for it, um and taken it on board at that particular time, whereas now it's just all the time, and
That's
probably
right.
people are coming into their pregnancy already with too much anyway because of our modern day lifestyle.
That's right. And so I think that's a really important thing to remember is that the impact of agriculturalization and modernization of our diet in the last 60, 70 years. I mean, now, we have the refrigerator, right? Because that wasn't a thing, 60, 70 years ago, where we can preserve food for longer amounts of time. And before our ancestors would, pickle food, they would preserve food and things that we wouldn't have access to it all the time. And so it would be very discrete times in our life. And so that's even actually something that I relate to with my patients in the first trimester of pregnancy when we talk about nausea and vomiting, because the evolutionary biology is really important to me, because I always figure like, well, what is the evolutionary impact? Why did our bodies evolve in this way? Well, nausea and vomiting in pregnancy in the first trimester is actually a biologic utilization of avoiding foods that could potentially cause food poisoning, but also introduce cancer causing agents in the first trimester, which is really interesting. A lot of women in the first trimester have this aversion to meat, right? And they don't want to eat a lot of red meat, and the smell of meat or like anything roasted really gives them this aversion. Well, the reason why that is because back in the day, we actually didn't have a way to preserve meat very well. And so when we would sacrifice an animal, it was actually like a really big source of food poisoning for people. And so if we didn't eat it right away or preserve it right away, then it would become a big source of food poisoning. And when do you not want to like introduce food poisoning kind of agents in your body? Is that first trimester? Well, then if you think about it, then when we were cavemen, when we would actually roast animal proteins over an open flame, it would have a lot of char on it, and charred pieces are actually carcinogenic, right? And so when do you not want to introduce potential like problems with DNA structure? It's that first trimester when the DNA is rapidly growing and replicating. And so that's really interesting to me. It's like actually a biologic utility to avoid that. But the same goes for certain fruits and vegetables. And so a lot of women have these aversions to different vegetables, particularly because of the lectin content that's involved in a lot of these vegetables that are anti-nutrients and cause food poisoning and gut issues as well. So it's really cool. Like, I think that when we look at the utility of where food was in our ancestors over thousands of years and how our body has changed over time, but then modernization really doesn't go in line with how our bodies were actually meant to handle nutrition. So it's a lot of fun. I love as it relates to pregnancy.
Yeah. So there's so many different places we could go today, and I know your time is limited. So where do you think would be a good place for us to head to? Do we want to head to perimenopause, or maybe a bit late? I'm sure my listeners are all shouting perimenopause, postmenopause, and
Yes,
they're probably
yes.
so where do you fancy going first? I mean, we could even start at teens. I part of my journey is I had a massive tumor on my ovary, aged, I don't know what age, 15, 16. Eventually,
Mm.
it was discovered when I was 17 and then removed just before my 18th birthday. Apparently, it was
Mm.
the size of a soccer ball,
Oh.
and they took it out along with 1.5 ovaries and my appendix. So, I just, you
Mm.
can't go back, but it would have been nice to have an option where I wasn't just cut into pieces and body changed, hormones changed everything. So,
Yeah, well, to relate to that, yes, we do have a lot of patients who will get these large tumors on their ovaries. It's a little different from polycystic ovarian syndrome, but whenever I'm on call in the emergency department and taking care of women in the clinic, we do get from time to time young women with large tumors on their ovaries. And a lot of times there's associations with metabolic dysregulation or people who are not completely healthy or they're very heavy on the starch. And so there is a lot of associations with women with all these kinds of benign ovarian tumors, with obesity, with prediabetes, with cardiovascular disease risk factors. We see that frequently. No one really knows why that is. It's not so clear cut as, like, for example, polycystic ovarian syndrome, which are tiny, tiny cysts on the ovaries where your body's trying to ovulate, but it can't for a lot of other reasons. These are tiny, less than 1 centimeter cystic kind of things on the ovaries. But a lot of women, especially with these big giant cysts, tend to also have these associations with metabolic and dysregulation. So I wonder, what that was like for you, when you were a youngster, if we've had many years of not eating well, and then we get to this point that we do, and we look back and we're like, oh, maybe that was my risk factor. It's hard to say.
Yeah, I mean, I'm sure my eating wasn't great. I ate a lot. I was always overweight from the age of as far back as I can remember being, when
Oh,
you look back, I probably wasn't that overweight, but I felt overweight compared to my peers.
that's
Um,
right.
and then yeah, you can see it now. Now you look back and you can see it. And I just think, isn't it wonderful that there is an option now to explore whether if it helps or not, we don't know, but it's something that people could explore if they're in that situation.
Yeah. Well, when we think about women as a lot of the women that I take care of are in their 40s and approaching the perimenopause and menopause time. And usually what happens is women start to kind of notice a heavier menstrual cycle or a more irregular menstrual cycle. And then they start getting evaluations by their general practitioner, primary doctor, or gynecologist. And sometimes they have what we call uterine fibroids, which are benign growths on the uterus that tend to stretch the lining of the uterus or cause pelvic pain. And the stretching of the lining of the uterus makes more surface area for more bleeding to happen. Uterine fibroids are actually cardiovascular disease of the uterus. And I know that's a pretty big statement to say, but what we know in terms of the pathology, the histology, the actual cells of uterine fibroids, when we look at them under the microscope, they're actually very similar or almost identical to the cells that cause hardening of the arteries or atherosclerotic disease of our peripheral vasculature. And so when we have women that have these fibroids, and unfortunately 70 to 80% of women in their lifetime will have uterine fibroids, it's because their body's receiving inflammation that leads to hardening of the arteries, which the uterus is one big blood vessel. The uterus is made of the same muscles that the lining of our peripheral vasculature are. And so when it receives inflammation all over the body, the uterus takes that and turns them into these benign growths of calcifications. And it's a big reason why women get hysterectomies. And so there's a couple of different things. And so some women have heavy menstrual cycles from a few other reasons. Some people have irregular menstrual cycles, and that's from a more hormonal reason. And then there's people who have both of these things. And it tends to show up in our 40s because of the many years of metabolic inflammation that we've had, this pre-diabetes, this insulin resistance that over years eventually brings women to this state of not a very good gynecologic health. And so when they talk to their general practitioners about it, then the GP is automatically like, go see your gynecologist. That's like a women's issue, right? And so that's actually not true. What brought women there was a pre-diabetic disposition, insulin resistance, high glucose levels. That high insulin levels can actually block ovulation. It's actually nature's way of protecting a woman from a time where she's in a very stressful time or metabolically unhealthy time in our life. I mean, you probably know, Jackie, and had this experience, or friends that did, where they were in a really stressful time in their life and they missed a menstrual cycle, right? Or there's a death in the family or something. And all of us as women kind of innately know, like, oh yeah, that's because something stressful has happened, but and that's actually biologic. That's like a involuntary protective mechanism for your body to not have a baby at a time that's very stressful in your life. Whatever the stressors are, it doesn't matter. Your body sees it as the same thing. And so when there's high stress, your insulin level goes up. Well, stress, but also glucose does that, right?
Yeah.
And so if you're metabolically unhealthy, then it's going to raise your insulin level to block ovulation. And so then your period doesn't come every month. And so for a couple of months a year, that's okay. But for a long period of time, I mean, there's a lot of women who don't have a period for 6 months, 12 months, those time at a time. And that's not normal. That's not menopause. That's high insulin levels that lead to blockage of ovulation. Well, then unfortunately, those women have a little higher risk of getting uterine cancer, because when you have a lot of estrogen feeding the lining of the uterus, it just grows and grows and grows and grows, and it doesn't go through the ovulation phase. The ovulation phase is what protects a woman from uterine cancer. And so if you don't ovulate every month, then you do have a higher risk of that. And so that's the irregular period piece that comes even before perimenopause or menopause. But then women have these heavy periods also that could be from fibroids, but it can also be from small, tiny, microscopic blood vessel inflammation at the lining of the uterus. And so a lot of women get heavy periods and then they get their ultrasound and their uterus is normal. And that's incredibly frustrating for a lot of women, because it's like, well, then what's wrong, right? Well, the ultrasound can show us what's going on microscopically at the lining of the uterus. And so if the lining of the uterus, those blood vessels are inflamed from metabolic syndrome, from prediabetes and stuff, then those little blood vessels won't constrict when the lining has shed. It takes them longer to constrict. And that's why people have these heavier periods and they're going through pads an hour and stuff. And so that's another thing. It's also a reason why people get uterine polyps and stuff. And so all of this to say is that a woman's journey through womanhood is very much impacted by body inflammation and insulin and glucose, because it impacts not only our hormone system that regulates ovulation, but it also impacts the structure of the uterus too. And so that's very much improved by trying to figure out, what is my inflammatory trigger, right? Because you probably also know folks that are hardcore keto, hardcore low carb, carnivore, and they still have heavy periods or other problems and stuff. And so, but when I see patients in my practice, I try to figure out all their inflammatory triggers, right? So maybe it's low vitamin D, maybe it's gluten, maybe it's low vitamin A that comes from seafood. That's really important to help our microbiome, our intestinal microbiome that prevents a lot of this stuff. Maybe it's sleep, right? Maybe they're night shift workers. Maybe they're in a toxic relationship or in a toxic job or workplace. And so that being said, like, it's not just diet. Diet's one really important piece, but sometimes it's not just one thing. It's a variety of different things.
Yeah, it's the whole lifestyle piece, isn't it?
It sure
Getting out
is.
in the sunlight, making sure you get to bed at a reasonable time, not too much blue light, keeping stress levels down. All these things are going to impact how we respond.
Yes,
So
it really does. And
how are you helping people do so? You've got your gynecology practice and then you've got a separate telehealth practice. Do you approach those differently, or I'm guessing people that come to you for telehealth, they already know about changing diet and things like that, maybe? Or yeah, tell us a bit about how you juggle it all.
yeah, so that's right. So I really do try to commit to exploring all of these different thoughts and inflammatory triggers with women when they see me. It really just depends on how they present to me. So when I'm in my traditional academic gynecology, OB-GYN practice at Loma Linda in the United States, where we have like insurance and things, and we're limited by 20 or 40-minute visits, I try to do as much as I can in terms of promoting these concepts in the traditional practice. And I really do hit these concepts, and I teach women about insulin resistance and endothelial inflammation, blood vessel inflammation. But then I talk to them about lifestyle, medications, and surgery if they need it. And so some people are interested in all three. Some people, unfortunately, their body has received so much inflammation for so many years that medications or surgery is where they need to go first. And then while they get stable, because some women are bleeding heavily, they need blood transfusions and stuff, and so that's really challenging. You can't tell a woman to be low carb when she's like so anemic that like she can't even get out of bed, right? So a lot of times the information comes from the spirit, and the recommendations come from the spirit of stabilization, right? Let's get you stable. Let's get you through this crisis in your life. And then while we're trying to get healthy, we can add a little bit of hormone therapy or talk about surgery to stabilize you. And then we can talk about the concepts of nutrition when you're in a better state to receive that information. Not everybody's in such a severe crisis, but some people are. And so that's the wonderful utility of having all the tools in your toolbox to help women, not just nutrition focused or medication focused, but all these different things. When I have a telehealth practice, I have a special outside telehealth practice where I talk and do consultations virtually. I give a lot of people some information and education about how they can improve their lifestyle as a whole. Some patients who are in California and in the state of Florida, I can really give them real medical consultations, and everybody else worldwide, I do it in the spirit of education and teaching. But that's a lot of fun because I can spend an hour with them looking at all kinds of different things and really focus on the nutrition and the lifestyle and give them a lot of coaching in terms of what makes sense for their unique gynecologic need. And a lot of the stuff has to do with perimenopause and hormones and the change of life and menopause, which is so much fun because there is direct associations with women who are having worsening hot flashes, earlier menopause, worsening brain fog with worsening metabolic health. So we know that when women are more insulin resistant, who have more struggles with obesity or diabetes, they tend to have worse perimenopause and menopause symptoms because that will dysregulate or change a lot of the temperature centers in your brain to cause those night sweats and allow people to be a little bit more triggered or irritable or have trouble sleeping during the menopause phase of life. And that phase can last 10 years. And so that's really hard. So the average age of menopause is 51, but these symptoms can present up to 10 years before your final menstrual period. I mean, I'm 46 and I'm in that phase. And so, last night I did not sleep well. I just was waking up every couple hours, and I just couldn't figure out why. And I do pretty good, but it was the weekend. Maybe I had a little bit more carbs with my family. I don't know, and so, but that's probably, it, and it very much impacts that. Even like a small amount can impact some women. And so, but it's really important to connect the dots about how insulin resistance can really change the woman's experience of menopause. And that's a lot of fun to talk about.
So are there things that you would say to someone who's perimenopause that would be different to those that are postmenopausal?
Yeah. So when you're perimenopausal, it's important to embrace that your stage of life is a little different from what it was 5 to 10 years before. And it's not that women can't handle stressors like they used to, but it is different. And so we become a lot more mature. We become, we have more wisdom than when we did when we were younger. And so, because of that, it's important to regulate our amount of activity, but also level of work and commitments to many things, to more of a mentorship and to be more of a leader rather than a doer in a lot of things, because we have a lot of wisdom that was different from our 20s and 30s. And so that's kind of nice, so that when we have that level of mentorship and leader, then we don't become so exhausted from the actual physical day-to-day of regular workplace and life and things. And it's also a time where we tend to lend more advice to women that are younger, going through childbearing and things. And then when we talk about menopause and how that is different, well, there is also biologic utility for the menopause symptoms that women experience. And this is really cool. So when we go through menopause, a lot of women experience hot flashes, right? And they happen at night. Well, the biologic utility of that actually comes from the time of when we were postpartum and we experienced hot flashes during that postpartum period. And that has to do with because there's a lot of parallels between the way women feel in the postpartum phase to when they feel the same thing in menopause. And the reason why that is because women of the menopause phase of life ancestrally were meant to help women who are recently childbearing, right?
Yeah.
And so that radiant warming of the hot flashes and stuff is actually present to help warm the new baby.
Yeah.
And to be an assistant, to be a helper in this community-based living that we used to live in a long time ago. And so to give the mother a break when the grandmother is having a hot flash, that's actually very helpful for the baby to have the baby on her during that time. And that's where the sleeplessness comes from and the quick to awaken, because that was meant to help our young mothers with protecting the baby to be awake and available to help overnight. And so that might not always be helpful to women when in modern culture because we don't live in multi-generational families anymore, but it may speak to that interest that older women in their menopause phase of life of what is the utility of this? Why are we having this? Well, so that we can help our younger generation, and maybe that'll bring some purpose to what these symptoms and feelings are really about.
Yeah, that makes total sense. And I'm wondering if it's different, not different in terms of our physiology, but how our modern life has evolved in where a lot of women are much older having children now. So the the grandmothers are much older as well. And
Yes,
they
yes.
in turn, so me, I didn't have my kids till I was 40. That was my grandma's age when I was born. You know, she was 42 when I was born. So she would have been doing this grandmotherly thing, but yet I was doing it as a parent with the additional stress and all the things that come with it. So I'm curious as to how our change in when we have babies is affecting all this natural biological features that we have.
It does, and not to say that it's not right also, right? Because we are still physiologically, a lot of women able to have children in our 40s and stuff. And so sometimes too, we use infertility treatments to help with that as well. And it's all good, wherever we are, I think it just lends to the programming of evolution and biology of what these phases in our life were for, right? And so sometimes when I'm going through a hard time or when there's something that's going on in my life that I don't understand, I really try to bring it back to what is the purpose of this, right? What is the purpose of what I'm experiencing in this season of my life? And so, yeah, and I think that like when you're in your 40s having children, and so then maybe that will lend to bringing your older generational family members to be more involved, right? To help improve their longevity, right? My mom and my mother-in-law talk about how their grandkids really do just bring them so much life and purpose and stuff. And so I think that is very helpful to these intergenerational cultures and women having children older, and that will help bring youth to older generations too. So yeah, I think at any phase of life, I mean, just lucky to have older generations to be with us to support us. That's what a blessing.
Yeah, absolutely amazing. So you said that we probably wake up during the night to attend to our children and our grandchildren, and yet we hear stuff around sleep. Oh, you must get sleep and you must be asleep, and yet we find I used to sleep 10, 12 hours a day every day. It didn't bother me. I'd still wake up in the night because I have done since that operation. but I could sleep forever. And now I can't. Now sometimes I'd get up, go to the toilet, go back to sleep, and that was fine. And now I might get up and go to the toilet and I might get back to sleep, and then again I might not. So do you think this not being able to sleep through the night or all through the night for women is as negative as we're led to believe by the sleep experts?
Yeah, I think it just depends on how it's impacting a woman's life, right? And so it really depends on what your day looks like the next day, or if it's that a woman is unable to sleep because their brain is going and they can't stop the thoughts of maybe things that they're trying to strategize or worry about or anxiety and stuff. And so I think I struggle with my own anxiety because I have a lot of things that I'm always trying to do. And so at night is when I get like my best thinking done, but it takes a lot of time for me to fall asleep sometimes. And so I know that when I'm having trouble falling asleep because I can't turn off my thoughts, it's like almost like an internal gauge of like, oh, okay, I might actually be doing a little bit too much, and so I need to kind of regulate that. And so it really just depends on how much it impacts your life. I think that if you can get by when you're getting a little bit older on 5 to 7 hours of sleep, a lot of people do, and that's actually pretty normal. But we do think that 7 to 8 hours is very helpful just because we want to be able to heal. That's a time that our body and our immune system tries to repair any damage that's gone through the day and through our life and stuff. And so digestion happens at night too. And so if we don't feel refreshed in the day, then that might be a sign that we need more sleep. And there's a lot of things that to relate to that too. I mean, it could be sleep apnea. If you're snoring, you don't feel refreshed and stuff too, because the sleep apnea means your body's kind of in a crisis mode trying to get oxygen. And if you're constantly waking up in order to get oxygen to go back to sleep, and that's unfortunately a sign that your body's under a stressor. And a lot of folks that struggle with diabetes, obesity struggle with that as well. And so it all is all related. And so I don't think that women should feel terrible that they're not getting enough sleep, but if it's not impacting their life in the day, that's okay. But if they're really feeling sluggish, then there's something out of balance for sure.
I can see on your bookshelf behind you, you got Fast Like a Girl. Do you
Yeah.
agree that women should be eating according to their cycle, or if they don't have a cycle, according to the moon and fasting in that way? Is that something that you would agree with?
I think it's a really smart concept that Mindy has kind of discovered and worked through. I do think that fasting for women of reproductive age might be a little bit of a blanket statement. I don't think women should be fasting the whole time of their month. I think that there is biologic utility to bringing a little bit more carbohydrates and food during that week after ovulation, because that's the week that your body's preparing for conception. And so you don't want to be under hormesis or really trying to turn over tissue turnover and, stress your body during that time. So a lot of women that I speak to and see that tend to be fasters, they tend to sometimes it's almost like overdoing it in a way, because they'll start to have spotting before their menstrual cycle. And if they're having spotting for a few days before their menstrual cycle, sometimes that's perimenopause, but sometimes it's that their body's under a little bit too much stress and their ovulation wasn't quite as robust as what we would want it to be, because they've eliminated so many carbohydrates and they've fasted for so long. And during that week before or right after your period is a time that really you should include a little bit more carbohydrates and starches and stuff. And that will a lot of times get rid of the spotting that happens and creates more of a robust ovulation.
Yeah.
And so I think it really just depends on what women are doing and stuff, and to kind of go with the natural feelings. I mean, I know with women who have PMS or premenstrual syndrome, they talk about wanting a lot of carbs like right before their period, and that really just means that there's a little bit of metabolic dysregulation. There's a little bit of prediabetes, that their body's really craving these carbs, but it's actually a natural phenomenon to make sure that your ovulation is robust and you can receive a fetus or pregnancy well during that time. So I do think fasting is great. I do think that women shouldn't fast like men.
Yeah.
I really think that they should fast according to their cycle, or I'm not really sure about the lunar calendar parts and stuff, and I think that's really interesting that I'd like to, learn more about. But I think that when a woman goes through menopause, they're able to fast for longer and not necessarily during it. They don't have to worry about the ovulatory phase
Yeah.
and how that impacts.
Yeah. So there's a great book called Moon Time, and it explains everything in life around the moon, including when to plant plants, when to do operations or have an operation, and all these things. So yeah, it's really good.
Oh yeah, there's a lot of information or truth to that, about the cycles of the moon. And oh yeah, I mean, we see it even kind of jokingly, we see it in the hospital where, we see a lot more challenging cases, a lot more women in labor, during the full moons and stuff. There's a lot to that.
Yeah. So I'm very aware of your time. Is there anything that we haven't spoke about today that you'd like to touch on or talk about?
I just want to tell women that, we are not just a silo of female hormones, that the majority of a lot of gynecologic problems that occur for women really have to do with insulin resistance, with too much carbohydrates, and then our body is kind of reacting accordingly. When it happens over a long period of time. And so a lot of women come to see me and they want their hormones checked, their female hormones checked. And as long as they're having a period every month, their female hormones are just fine. It's really mostly insulin and inflammatory concerns that are happening that are kind of causing this dysregulation. But some women just don't have even the words to describe what it is that they're experiencing. They just feel that it's something very unique to their womanhood. And so then that's where it's a lot of fun because we can teach how so much of modern culture and diet and nutrition and stressors are impacting our womanhood. I really do want to share is that if women are experiencing just this imbalance of menstrual cycle fatigue, premenstrual symptoms, menopause symptoms and stuff that are really exaggerated, that it's okay, that let's figure it out together. Let's look at how our diet and our lifestyle is impacting. And it's not just because we're a woman that we're experiencing this, but it's how we as women manifest dysregulation. So I'm just would be love to help women through that and share. And that's really but what my YouTube channel is about, Conscious Gynecologist. It's what my personal practice is all about. And it's the big basis for my clinical research. So thank you, Jackie, for this opportunity very much to share.
Yeah. So how can people contact you, find you?
Yes, thank you. So I have a YouTube channel. It's called Conscious Gynecology, and you're welcome to look at there. A lot of videos I have about endometriosis and PCOS and menopause and all those things. And I also have an Instagram account called Conscious Gynecologist. I have a website called consciousgynecology.com where people can have set up appointments with me. And my email address is on there and stuff. And so people can contact me with any questions that they might have or considerations for consultations.
Great. And so we always finish with your 3 top tips.
Yes, 3 top tips. Wow, great. Sleep well.
Yeah.
Make sure that your life is that you have quiet time for yourself to reflect on your goals, and don't eat too much carbs.
Yeah. Which I guess most of our listeners are not doing.
Yeah, that's right. That's right.
Fabulous. Thank you so much for being with me today.
Yeah, thank you, Jackie.
I thought it was fascinating when Andrea spoke about gestational diabetes and how physiologically women are meant to take on more sugar during pregnancy to help the baby grow. The issue today is that thanks to the standard American diet, SAD, or standard Western diet, and the high sugar, high carb nature of modern eating, many women are already entering pregnancy with elevated glucose levels. That constant intake sets the stage for gestational diabetes to develop, rather than it being just a natural rise in glucose to support the baby. Another thing Andrea shared was why we tend to wake more easily in the night. as we go on later in years. And she was explaining that ancestrally, this was a time when women helped the younger mothers care for their babies. This increased alertness had a purpose: to keep the baby safe and to help mum by looking after the baby and so ensuring that the family thrives. I thought it was such a helpful reframe for those sleepless nights to just remind ourselves that there might be a biological reason for being awake, and it's okay not to sleep through the night. I especially loved it when Andrea said, "What is the purpose of what I'm experiencing in this season of my life?" And that reflection invites us to explore how our bodies might be working for us, not against us, even when things are feeling tough or hard. I hope you enjoyed this episode. Disclaimer. The content of this podcast is for informational and educational purposes only and is not intended as medical advice. Our guests, whether healthcare professionals or not, are sharing their personal opinions and experiences. This does not establish a doctor-patient relationship. Always consult a qualified healthcare professional before making changes to your medications, treatment, or lifestyle, particularly if you're on medication or have concerns about your health.